Stapes surgery, primary otosclerosis. And the reason why I put it online is because we have a really difficult situation here, which is part of a complication in Stapes surgery. What you can see here, this is the left ear, so this is 12 o'clock, 3 o'clock and 6 o'clock. You can see here the incus, right here, and the stapes. But the problem that we have is that there's a really narrow oval window. You can see the superstructure is connected to the fallopian canal. First step will be to separate now the incus from stapes, désarticulation. And then I will check the ossicular chain mobility. So I need to go within the joint. There we go. And now I can check the ossicular chain mobility. You can see the problem that we also have is the bleeding, which is due to this lots of vessels there. So you can see malleus incus both mobile and stapes is fixed. Plaron encore, s'il vous plaît. So of course now, plaron, après les ciseaux. So the next step, vous pouvez la prévenir là, s'il vous plaît. The next step will be to cut the tendon, of course. Now I will cut the stapes tendon as usual. There we go, and we're going to start drilling out the superstructure. I'm going to start with the posterior cruce. Cannelé, s'il vous plaît. You can definitely see here what we have is the really, you can see a connection between the posterior cruce and the fallopian canal, but it's not a problem. There is no connection in terms of final, definite, permanent adherence. I mean, it's just connected, but there's no adherence there. Table vers moi, s'il vous plaît. So what we're going to do now, I will start drilling out the posterior cruce first. Stop. And the bleeding that we have is also a problem, as you can imagine, of course. This is a situation on life where we just have to be patient and just wait and keep going on, step by step. La fraise, s'il vous plaît. Ok. D'accord. Ok. Okay, so let's try now the posterior cruce. So of course I stay away from the facial nerve, from the fallopian canal. You can see I'm going to the promontory rather than to the fallopian canal, and I go step by step. And now the posterior cruce is nearly cut. That's going to be fine for the posterior cruce. And now I need to do it with the anterior cruce, which is very difficult to reach here. La fraise encore. So I will try to reach it from right to left. There's no way to do it on opposite. So I need to push a little bit the anterior cruce and start the drilling before going down. I think you need to be sure about the reaction of the burr, which needs to go in the right direction. So sometimes when you start the drilling out, it can go straight to the right or to the left, so it's better to test before. I think it's fine. So I know, of course, where the landmarks are. I know exactly what I'm doing, and that's it. And now we should have access to the footplate progressively. We have a very large airborne gap with this patient, something like 60 dB bone gap. And what you can see is the second problem that we have is still the, I mean, it's the same complication, same issue, is that we have a very narrow oval window. You can see that, so we need to, and an obliterative otosclerosis. See, the oval window is very narrow and obliterated completely. So we will do it step by step. Donnez-moi un peu de gel forme adrénaliné. We have this bleeding here right in the middle of the field, which is due to the fact that we have lots of microvessels everywhere over the footplate. So what I will do, I will try to stop it, to control it with some adrenaline and gel foam, but it's not going to work well. We have a really narrow situation here, so it's not going to work. Okay, so we need to wait anyway. There's no other option rather than waiting, because you see this bleeding is there. So la fraise. So I don't want to measure right now, because it's clear that it's not going to be the right position of the footplate, which is really thick. So I will start the drilling out procedure right now, and of course I will have lots of problem with the bleeding, which will be increased by the drilling. There's no other way anyway. So I do it with the micro drill, and I just don't make any pressure. You know, we know that this type of footplate, we don't want to dislocate them, so we need to do it very gently, and of course again away from the facial nerve. So you can see it's more to the promontory. I know exactly again where the promontory is. So here on the left there is no risk with the facial nerve, and we have a really strong bone here. This is due to the long-term evolution of the otosclerosis. This patient was thinking a lot before going for surgery, but now of course she has a severe hearing loss, also beginning on the right side. Vous pouvez m'aider là s'il vous plaît? So it's really time to do it, but of course, because it was waiting a lot, it's related to this, that we have now a bony, kind of a bony footplate. So it's long-term procedure here compared to the regular one, which is faster, but there is no other way. We need to take care of everything. So, and the problem is that everything is very narrow here, including the ear canal, so I cannot use very easily both instruments at the same time. C'est un 9 que j'ai là, c'est ça? Oui. We're going to continue like this. And we will see. And of course I will have to measure at one point, but not now yet. It's a difficult case, but I mean it's interesting to show difficult case, how to deal with, just to show that even with experiment surgeons still have some problems, some issues with this type of presentation. There's no way of doing it differently. Taking the time to do it. You see how thick is the footplate. So we have a combination of really difficult complications. Facial nerve and the another facial nerve, which is not decent, but I mean the narrow oval window and obliterative footplate. So I keep going on like this, increasing a little bit or enlarging a little bit the drilling out area. Calmez s'il vous plaît. Ça va. La fraise. I'm going to enlarge the posterior area like this, drilling out posteriorly to flatten a little bit more this area. Now it's getting slightly better, as you can see. You can see now the white aspect of this footplate and oval window. Okay, like this, you can see the difference now. So we need to continue the drilling out. The bleeding is less now, which is very good. Okay, so vous donnez-moi du sérum s'il vous plaît à côté. So I will use some saline solution to du sérum s'il vous plaît à côté avec la cupule. Voilà. So I will refresh with some saline solution to decrease the heating. The risk also here in this case, especially when we have such a thick footplate, is that we can heat the labyrinth if we drill too much. Definitely it's a long procedure. There's no other way, as I said. Take more time. Vous me changer la fraise s'il vous plaît, so I will change for another burr, which works better, I think. Encore du sérum, s'il vous plaît. You need to stop at some point, step by step, otherwise the risk is to hit. problem is that the really hard bone, so this is not good. It's working. You can see the effect on the bone. A really severe obliterative case. Okay. Still thick, but it seems to be that to me that the bone is not so hard now, but it's the question of feeling. It's difficult to know. Changez la spie s'il vous plaît. Encore le sérum. Donnez-moi le cannelé s'il vous plaît. I have some fibrous tissue here coming to the right, so I just prefer to remove that. So part of the bone. Okay. La fraise. Still, you know, still thick. You can see the thickness. It's quite of the thickness of the size of the burr, which means 0.7 millimeter. Encore du sérum, s'il vous plaît. It needs to be a low speed drill for the same reason, because I don't want to hit the labyrinth. And also you have to stop at some point every 30 seconds or something. You can feel the resistance, I tell you, it's still strong. I thought it was getting better, but still. Very impressive to see as much as how far it can be, or deep it can be. Becoming a little bit blue now, a little bit. But as you can see, I take my time before creating the final fenestra. I think we're not so far now. The problem is that if you increase the speed, then you can feel the vibration in your hands, which is not good for the labyrinth, I guess. So I think it's better to take more time and to use low speed, leaving the diameters doing the job by itself. It's very rare, I tell you, to have such a resistant bone, such a thick and hard footplate. It's getting really better now. I can see it's becoming more translucent. I think I'm not so far, but it takes a long time, even for the thinnest part of the footplate. You can see it becoming more blue, but still thick. You can see now it's more than 0.7 in terms of deepness, so it was a very severe obliterative case, very thick footplate. This, of course, explains the importance of the airborne gap that we have. And of course we need to stay very vertical, perpendicular to the promontory and the fallopian canal. Becoming really blue now, which is the perilymphatic membrane, of course, as we know. Okay. Becoming better. I can see that, but still I do it very gently. Definitely blue now. I can feel much less resistant. I think we have some, it seems to be that we have a little bit of fluid coming out. I'm not sure about that, but maybe we have. Yeah, now it's becoming really much better. So I'm going to measure soon. You can see now. I'm going to measure now. Mesureur. It's a very short incus. Interesting to see. I'm going to cut it at 3.5 at the moment. It's very small distance, short distance between incus and footplate. La fraise. Canet d'abord, pardon. I set maintenant, so I'm going to use 0.7 millimeter diameter sucker now because I'm very close, I think, to performing the fenestra. Much softer now, you can see, of course, it's very thin. Not very thin, but much thinner now. You can see a little bit of fluid coming in. Still not done, as you can see, still bone. I can feel with the burr that it's still resistant, but I think it's very close now. There we go. Yeah, it's done. I'm going to check, but I think it's done. You can feel it when you open up the fenestra. That's it. That's done. We've got some residual bone around, but I don't mind. Mesureur, and I will measure again just to be sure that it's going to be a short one. Yeah, definitely 3.5. All right, so I'm going to put the vein now. Bistouri d'abord, s'il vous plaît. So you see the vein, which I prepared before at the beginning. I will reduce the size, it's a little bit too much. So I'll remove just this part. Okay, so now I will unstick the vein from the glass plate all around. That's it. Now I need to put it on the other side. Now we're facing the adventitial side. Now this is the intima. Changez-moi la pour un 9 s'il vous plaît. Oui. Ben un autre. Ok, mettez-moi un peu de sérum s'il vous plaît. Oui, oui. It's a little bit too dry, so I need to put it a little bit of... Okay, fine. All right. Candy. All right, so now we need to insert the vein. There you go. We have a nice position of the vein. And now I need to prepare the piston. Okay. Okay. So I use a regular cross piston, of course, with a 0.4 millimeter diameter shaft. Another loop. 3.5 is really pretty short. Plat rond, s'il vous plaît, d'abord. Ok, allez, inspiration. Alright, so I will place first, I will insert first the shaft within the vein and the fenestra. And now I need to place the loop around the incus. Cannelé. And it's going to work fine. Good. Into crochet. So we just need to close it now and it's going to be okay. So really difficult case, but really interesting to put it online. Hope it's always fun to see experienced surgeons sweating a little bit. But I think it's more interesting sometimes to show difficult case rather than only basic cases. There we go. I think it's fine. We're going to check the bending sign, and this is what we have. You have the bending sign, mobility from malleus, which is fine, so it's okay. So let's now reposition the flap and then put the middle cell as usual. Un 12, s'il vous plaît. Un 12. Un 12. All right. You can see the narrow canal that we also have, with also thick skin, in fact. All right, so it's fine, and let's put the middle cell now. Allez-y. Okay, thank you very much for watching. I'm sure you enjoyed it. It was really interesting for me to show you this, and hope you're going to see you again soon. Fine. Thanks a lot. Bye-bye.